All right, so let's go ahead and get started. We're already 10 minutes into the class. We can definitely try and figure this out on a day where we're not having class. Maybe I can arrange a time where we can just do a test run.
Okay, I'll let the director know.
Great, thank you very much.
You're welcome.
But Kelsey, you can at least see me and hear me. So we'll go from there. So this is coding week 2. And we're going to be going over answers tonight for chapters 1 through 4. And then start into chapter 5 through 10. What I would like to do right now is just share my screen for a moment so that everyone gets an idea of what you should be seeing when you log on to Evolve. Now, I'm seeing a really small picture, so I'm not sure if you guys can see this any better than a small picture. Give me one moment. What you should see here is the Evolve resource for health insurance today. And the course ID actually has my name in it, dbovin1, as the instructor. There are some students who have signed up and they have global in the course ID. You really should have the course ID that you see listed here in the screen sharing that I am showing you. Are you able to see that at all, Kelsey?
Yeah.
Is it clear?
Yep.
Okay, because I'm only seeing this small little picture. So once you get onto the Evolve resources for your health insurance and you click into it, what you're going to see over on the left-hand side are all the resources that you need for the course. So the student resources. And you don't have a workbook. So just to be clear, there is not a workbook. You just have the textbook. And then all of the what did you learn in the chapter, those questions are things that I really want you to take the time to answer. And they're not anything we have to pass in, because you're going to take the chapter exam or quiz afterwards, and you're going to see it within each chapter. So when you see chapter review questions, those are your quizzes or exams to take and put the grade on your checkoff sheet. Underneath chapter 1, it really just gives you some websites to explore, and I did indicate last week that it would be a good idea just to, go onto a few of these and see what they have to offer, just to kind of show you the different things that are available to you out there. Also, make sure you are using Google Chrome or Mozilla, because those are what Evolve works best in. All right. So that will be it for Evolve. Give me one moment while we get into place here. All right. And so, Kelsey, you should just see a picture of me now, right?
Yep.
Excellent. So let's start off with, how did you do with the homework? How did you feel after the first few chapters in the lecture?
Am I the only one with you?
Yes. sadly,
Okay.
Kelly had to leave. She had some children.
Well, honestly, it was hard not being, not doing it with you
Mhm.
on your own. It was just kind of, I didn't know really where to start and where to go. And
Okay. So that's why I assigned the what do you learns, and we can talk about those tonight. So let's start on page 3 in your textbook. And we're just going to go over a few of the what did you learns. Now, last week we compared health insurance like a picture puzzle. And if you look at the top of page 3 in the left-hand column, excuse me, you'll see that insurance is like a puzzle. We start off in the middle with the providers, and everything branches out to the different payers and the type of coding and the people who are involved. So if we had to describe insurance, insurance is simply the act of business where through legal means, usually a written contract, we are protecting an individual's property against loss or harm. Usually it arises out of certain circumstances, and then there's a return payment. Hi, Kelly. Okay. So we have Kelly and Kelsey. Kelly, are you wireless or hardwired? Okay. And usually when the insurance returns a payment, that is, or when the person pays for the insurance, that's what's called a premium. All right. When we talk about medical insurance narrowing down undesirable events to what two categories? Well, they all happen, and they happen more often to some than others, but the two undesirable events would be illnesses and injuries. And then number 3, what is the term used when medical services and procedures are performed to keep a person well or prevent a catastrophic illness? Real simple, preventative medicine. So one of the preventative medicines, actually chiropractic, that is considered preventative medicine. When we go for our annual checkup, that is considered preventative. When we go for screenings, that's preventative. All right, so let's turn to page 4. What did you learn? So what is the Latin word for insurance? And what is the actual literal English translation? The Latin word would be securitas. I'm not a Latin major, so bear with me. And when it translates into English, the word would be security. State when and where the birth of health insurance occurred in the United States. That was in Dallas, Texas in 1929. And then what did early insurance policies in the U.S. typically cover? That would be loss of income, health benefits, usually for a limited number of what was then common serious diseases such as lupus, typhus, typhoid, scarlet fever, smallpox, diphtheria, and diabetes. All right. So were those some of the same answers that you got, Kelsey?
Yeah.
Okay. Really, what I'm aiming for in the what did you learn was really, did you read the chapter and are you able to pull out the information here? Because these are the major points. And then if you read over the critical thinking or the stop and think or the imagine this, it gets you thinking about insurance and today. Okay. Page 7, what did you learn? So how is the transformation of health insurance from what it was in the beginning to what it is today comparable with the metamorphosis of a caterpillar to a butterfly? Well, metamorphosis is considered a profound change in the form from one stage to in the life of a history or organism. Hi, Kelly.
Hi, I'm so sorry. I don't know. My computer's acting up.
That's okay, it happens. We're on page 7 in the textbook.
Okay, thank you.
You're welcome. So we're answering the what did you learn? So I'm talking about number 1, where metamorphosis is a profound change in the form of one stage of life to the next in the history of an organism. So basically the transformation of health insurance from what it was in the beginning to what we know it in being today has gone through many stages and numerous profound changes also. I think you can see that by this chapter and the pie charts. So why are some people in certain organizations in the U.S. opposed to governments getting involved in health insurance? Because they're afraid that if the government becomes involved in health care, it will lead to what is considered socialized medicine, where a public tax-supported national health care system becomes, and then most people will feel that this is not in the public's best interest, because the access to health care would then be limited. Number 3, what 2 federal programs got their start in the 1960s during President Johnson's administration? Kelsey, can you answer that?
Who?
That would be Medicare and Medicaid.
Yes.
So then the 3 major changes that were made to healthcare in 2010. The first one would be that insurance companies were no longer allowed to deny coverage to children with pre-existing conditions. Children can then remain on their parents' insurance policies until they are 26 years old. And Medicare recipients who fall into a specific coverage gap receive a $250 rebate. All right, let's turn to page 10. What did you learn? So let's list 5 of today's key health insurance issues. Now, there are some different answers out there because some of the former issues have been resolved. So if you had any of these, it would be appropriate. Keeping costs down, regulating health insurance industry, introducing more effective medications and treatments, stabilizing the utilization of emergency departments, preventing chronic diseases, protecting patients' privacy, and expanding the use of EMRs. What are the two major sources from which most people acquire health insurance? Usually that would be a government-sponsored program and or private organizations. Number 3, a set of government-regulated standardized healthcare plans eligible for federal subsidies from which individuals can purchase low-cost health insurance describes what? This would be a health insurance exchange. A health insurance exchange. All right. And then number 4, what are the 4 key factors that drive healthcare costs up? We have Americans that are living longer than ever before, which is really cool. Advances in medical technology, the rise in chronic diseases, more demand for healthcare, and media intervention. Number 5, 4 ways the Affordable Care Act helps to curb the healthcare costs. You could have some possible answers such as stopping the insurance company abuses, cracking down on Medicare waste and fraud, eliminating certain subsidies to private insurance companies, introducing payment reforms that allow providers to deliver more care effectively, offering tax credits to small businesses to help cover those health insurance premiums for their employees, making affordable insurance exchanges available for individuals and families purchasing coverage in the health insurance market, and providing tax relief that cuts the cost of insurance while guaranteeing access to basic health benefits. Number 6, how does cost sharing help keep healthcare costs down? Basically, cost sharing is when individuals pay a portion of their healthcare costs, such as the deductibles, the co-insurances, or the co-payment amounts, which usually will ease that burden or on the health insurance payers. Page 11, what did you learn? Why do people need health insurance? Why do you think, Kelly? Why do people need health insurance? Okay. Screen's frozen, so I'm assuming you're having trouble. That's fine. To protect them from paying out large sums of money, sometimes to the point of bankruptcy, for qualified medical care. Number 2, name the 2 basic categories of health insurance. We have indemnity, which is fee for service, and managed care. And how would we briefly describe an ACO? An ACO can be taken basically from your book. Authors of this coverage structure have formulated ACOs to provide a new, more efficient way to deliver care. It is similar to an HMO. It's a network of doctors and hospitals that share responsibility for providing care to patients. And under the new law,
Their printer machine is in this room. I think that's what you heard.
Yep. Under the new law, ACOs would agree to manage all of the healthcare needs of a minimum of 5,000 Medicare beneficiaries for at least 3 years. And then it goes on to tell you what those goals might be. And then that would be it for chapter 1. Did either of you have any huge questions that stuck out for you in this chapter?
I mean, I think it's all pretty right out there in front of you.
Yes, I actually liked the conciseness of this chapter. They really didn't go into a lot of fluff. It was really pretty straightforward. I enjoyed that too.
Yeah.
Because not only as an instructor, but someone who works in the field, I want to be able to present information that is short, sweet, and concise and to the point. I don't want to have to give, big long spiels about it.
Mm-hmm.
Because some people find this type of work very boring. I don't. But it's a very hard topic to make exciting. So I'll do the best that I can, and hopefully I won't lose anyone along the way. So let's move right into chapter 2. And this one was tools of the trade. So we don't have to go over a lot in this one. But let's start with let's take a look at the stop and think. Okay, this one was reread the personality traits listed. Now, I know I didn't give this as an assignment. I just want to talk about it. Do you understand what each one means? And then reviewing the definition for each. Do you think you possess all these personality traits? If there are any traits that you would think you do not have or that you might need to improve on, well, let's just talk about the personality traits. And there would be a lot of varying answers on this one anyway, but let's just talk about them. Self-discipline. This is someone who is capable to do what is necessary or reasonable without needing to be told by somebody else controlling your impulses. Positive attitude, to look on the bright side, to be optimistic. Diligence, sticking with a task until it is finished, a persistent and hard-working effort in performing one's duties, the care or attention expected by the law in doing something, such as fulfilling the terms of a contract. Integrity, having honest, ethical, and moral principles, possessing and persistently adhering to high moral principles and or professional standards. Objectivity, the ability to perceive or describe something without being influenced by personal emotions or feelings, biases, or prejudice. Initiative, the readiness and ability to act and make decisions without other people telling you to. And enthusiasm, the feeling of anticipation and pleasure when looking forward to life or a task. So just think about them and figure out which one you would be. What is your personality trait? And think about that as you go through this class. Because that's going to actually help you be successful in this course. All right. Some of the things that will help you being successful in this course are not only the items that I outlined in my email, but some of the more specific things might be to attend class. I understand that life happens and sometimes we need to, take a class off, or just let me know ahead of time. Become an active participator, ask questions, take notes. I do try to be interactive even with online students. So don't feel like I'm picking on any one person. It is a little more difficult when it is only 1 or 2 students online. But try to be active in the class. Outlining, underlining, and highlighting, those are big things. Making notes in your margins. Working through questions and examples until you can understand them. Communicating with me and other students. So if on an email you see all the other students are listed, then reach out to one of them and say, hey, I'm working on this chapter 2. How are you doing with it? Try to even create what you would call an online study group. And complete all your homework and assignments. Develop your ability to concentrate. I know that can be difficult with everything else that might be going on. And learn to recognize key points in the text. And then just be able to paraphrase and write down in your own words important facts from the lectures. Now, as we actually move on in the class into the actual coding section, I will be able to point out to you in the books things that you should highlight and underline. So let's go to what did you learn on page 17. Number 1, 5 required classroom skills. I just went over some of those. Actually, I went over these maybe in last class. Reading and comprehension, basic math, English and grammar, oral and written communication, keyboarding and office skills, and computer application skills. Why is preparation an important key to success? Because it will help us to set clear, realistic goals and objectives. It also helps to generate a workable schedule for maximum time management, helps us to also maintain our focus on our education, creating self-confidence, and allowing us to measure our success. It's like a measuring stick for our success. So if you have a daily planner or a calendar, I definitely suggest that you use that to set your schedule of when you will be doing your assignments, and block out that time every week that this is when you'll be doing your work. And if you have family involved or you live with roommates, however it is, you just want to make sure they all know this is your time to do this work. And then list 5 on the experience health insurance professionals should possess. Pay attention to detail. Follow directions. Be able to work independently without supervision. Understand the need for and possess a strong sense of professional ethics. Understand the need for and possess strong people skills. Demonstrate patience and even a temperament. Be organized but flexible. Be conscientious. Demonstrate a sense of responsibility and possess manual dexterity. Also, you want to understand and respect the importance of confidentiality. That's huge with what we do, and demonstrate a willingness to learn. Page 18, what did you learn? What are the 8 various roles that are included under the general umbrella of a health insurance professional? They list those there below. Actually, over on page 17, they list them in table 2-2, so I'm not going to read them all for you. Number 2, why do you think autonomy might be attractive to some career-minded individuals? Because some people work better when they have some say in how they do their assigned tasks. So when it's left to themselves and they're skilled and confident employees, they can usually work more productively and efficiently, usually without supervisors micromanaging them. Number 3, 6 typical duties of a health insurance professional. We don't think about it, but it could be scheduling appointments, bookkeeping, or other administrative duties. explaining insurance benefits to patients, handling day-to-day medical billing procedures, adhering to each insurance carrier's guidelines, documenting all activities using correct techniques and medical terminology, completing the insurance forms promptly and accurately. And those are mostly done in an EHR now. So it's just a matter of, are we putting the correct information into the EHR?
I do have a question for you.
Sure.
The CMAA, that basically just gives you the like the certification to do the administrative part. Is that correct?
Yes. Yes.
So if I'm not doing that part, does that prohibit what I will be able to find for a job?
Say
Or
that
kind of-
again, if you're doing just the medical administration part?
Well, if I don't do the CMAA, does that kind of narrow down the jobs I'll be able to find in this area of work?
No.
Okay.
No. Did you sign up for the professional?
No, just the billing, coding, and terminology.
Okay. So no, because what you're learning here in the billing and coding is basically two jobs in one. Because, and I haven't explained this already, when you walk away from this course, what will happen is you will have a certificate in medical billing and coding. So when you are looking for jobs, you'll be able to look for what they list here as the 8 various career options. You'll be able to look for a claims assistant professional or a medical coder and coding specialist, medical claims processor. You don't want to just type in medical biller, because you might not get just a medical biller. You might get something like they have listed in your book. Mm-hmm. So as you're looking for jobs, you want to look at these types of options. So what do they have for a billing coordinator? What do they have for a medical collector? You'll be able to go out there and be either or both.
Okay.
Because depending on where you end up, if you're in a small practice where it's just the doctor and yourself, you end up being the biller and the coder.
Mm-hmm.
Or if the doctor codes, you could just be the biller, which is just as, there's a lot of responsibility. Coding, believe it or not, is a really small piece to the puzzle. Because once you find the code, you're all done.
Yeah.
It doesn't take you but 15 minutes or less to find a code once you know what you're doing. But to bill effectively and efficiently and accurately takes a lot. So it's the balancing the two worlds and being able to do it. That's what it comes down to. And some people actually, once they do it, they prefer billing over coding and vice versa. So it's just a way to get yourself in the door as a biller and then maybe work your way up to a coder.
Okay.
Does that make sense?
Yeah, it does. Thank you.
You're welcome. All right. So those are some of the duties that we might be doing as a biller. Being able to understand and explain those things. So on page 20, what did you learn? How has HIPAA opened up opportunities for health insurance professionals? Well, what's happened is that it has moved the healthcare industry from paper claims to electronic submissions using the national standard format. It creates job opportunities for health insurance professionals to basically help the non-compliant providers achieve HIPAA compliance. And what does tech suggest might be the biggest reward for health insurance professionals? Basically, the knowledge that you are helping people. And for me, it really is, I'm not just helping the patient, I'm helping the provider so that the provider can see the patients and not have to worry about the administrative aspect of the work. So The more that we can do our job effectively and efficiently, the less the doctor has to worry about. Page 21, what did you learn? List at least 4 certification possibilities available to us. That would be CMA, RMA, CPC, CPCH, CCA, CCSP. It just depends on what you go for. When you're done this class, it will be a CPCA because you will have an apprentice designation, and afterwards you have up to a year to get that designation off, and it does tell you on the AAPC website how to work on getting that designation removed. What is the basic goal of health insurance professionals, coders, and collection specialists? Really, it's our job to ensure that the providers and patients get paid correctly the first time, every time, and on time. And computers have reduced the demand for health insurance professionals. That is false, because computers actually have increased the demand for health insurance professionals. Because just like being done on paper, you have to make sure it's done on there correctly. Well, you now need to make sure it gets put in the system correctly. So it really gave us more job security than before. Over on page 22, CMS mandates that insurance claims be submitted electronically with certain exceptions. That is true. And 2, the universal form accepted for submitting paper claims is called the CMS 1500 form, and it is version 2-12 or 2/12. And you see a copy of it right there on page 23 in your textbook. So any questions with this chapter?
No, I don't think so.
Great, thank you.
Actually, what is the highest certification that you can have? Or the best certification?
Well, I personally think it's the CPC, because from there you can go on to anything else. What you want to keep in mind is that as you add credentials to your CPC, you have to keep more continuing education credits. Mm-hmm. So just for a CPC, you have to have 36 CEUs every 2 years. So let's say you wanted to go into auditing or compliance or office management. Each one of those is another credential. It adds another set of, letters after your name. Mm-hmm. And by doing that, you add so many additional CEUs. So you might end up having to need as many as 72 CEUs per credential or total. So you have to keep in mind how you're going to do that.
And those credentials you can get by just like taking part in like an informatory class?
Yes, you can take and get some by doing webinars. I have done some doing webinars through some of the clearinghouses and vendors that I participate with. I also use the monthly magazine that we get as being a member of the AAPC. And then there are certain workshops that I might attend where I might earn, 3 to 4 or 3 to 6 CEUs. The chapter meeting every month is a CEU. So it's just, you can find some that are out there that you don't have to pay for, but then you might have to, buckle down and pay for some just to get your CEUs going.
Yeah.
I think the whole time I've probably paid for 6 different things just because I wanted the extra knowledge. as well as the CEUs. So I've paid for them through the AAPC and just done them online. I've attended some monthly meetings, but I'm not always able to because usually class is when the monthly meetings are. I do the monthly, we get the monthly issues in the mail. I do those online. So there's definitely ways to get the CEUs, but just keep in mind, as you add a credential, you increase the number of CEUs you need.
Right.
Okay, so chapter 3, the legal and ethical side. Let's turn to page 28. So what is the primary goal of health insurance professional? It is to complete and submit the insurance claims and to conduct the billing and collection procedures to generate as much money for the practice as legally and ethically possible in the least amount of time. What does the Latin term respondeat superior mean? Let the master answer. This basically means that the physician or the healthcare provider is ultimately responsible for the actions of his or her employees. It does not mean, however, that the employee does not share some responsibility in the actions. All right. Page 29, name and explain necessary elements that make a contract legally binding. The first one would be offer and acceptance. When you ask someone to do something or offer to see someone for a price, you are making an offer. And that's usually the first step in forming a contract. Then the next step is the other party's acceptance of the deal. Words, gestures, actions, they can signal an offer to enter the contract and the acceptance. And the last step is the performance, where each party lives up to his or her bargain. Page 30. What is an implied contract? An implied contract must be in writing and be enforceable. Actually, I skipped one. I skipped the answer to what is the implied contract. The implied contract is the contract formed through the acts or the conduct of the parties that are involved. True or false, an implied contract must be in writing to be enforceable. False, and explain the function of a third party in a contract. It's usually the individual or business entity that is not a party to the contract, but who has legally enforceable rights and or obligations under the contract. So in the health insurance contract, it's the patient's insurance company that is the third party. On page 31, legislation established that Medicare is a secondary payer in the case of an automobile and liability insurance policy. This would be the Federal Omnibus Budget Reconciliation Act, or OBRA, of 1980. For OBRA of 1987 to be applicable, how many employees must the employer have? That would be at least 100 full-time employees. What is the name of the act that allows individuals the option of continuing their group coverage in case they are laid off or quit their jobs? That would be the Consolidated Omnibus Budget Reconciliation Act, and that is COBRA. And what did TEFRA of 1982 make Medicare benefits secondary to? That would be the employer group health plans. Over on page 33, the difference between ethics and laws. Ethics are standards, basic standards of human conduct, sometimes called morals, usually of a particular group or culture. And laws are the rules of human conduct established and enforced by authority, legislation, or custom of a given community, state, or nation. What is the difference between ethics and etiquette? Well, ethics are the standards of human conduct of a particular group or culture, and etiquette involves following the rules and conventions governing correct or polite behavior in society in general. And some current ethical issues that are facing society today, they have a list of those here in your textbook. I'm not going to go through those. On the next page, 34, what are the 4 purposes of a medical record? They enable the healthcare provider to render medical care to the best of his or her ability. It provides statistical information for research, offers legal protection for the healthcare team, and provides support for third-party reimbursement. What items should be included in a medical record? Well, according to the Joint Commission, there are 4 factors that improve the quality and usefulness of the medical record. First one is timeliness. Within 24 hours of the encounter, it should be available. Second is completeness, documentation of the patient's problems and concerns. The third, accuracy, and the fourth, confidentiality. And what are some of the items in the medical record? Demographic, current release of information, drug or allergy flags, medical history. Those are just some of the things. Who owns the medical record? Well, the medical record is owned by the physician who's providing the care or the corporate entity. So here in this area, we have Prime Care Associates or Southern Maine Associates. Within that practice are several physicians. So if a record is created for a patient there, Prime Care Associates would own the record. They are the legal owner of that record. Now, the information contained in the record, however, is technically the patient's, and it cannot be divulged to anyone without a written consent. The usual retention policy is to meet the requirements for good patient care, healthcare providing legal and ethical obligations, establish guidelines for retention, purging, and destruction, and then to conform to state statutes. Page 36, what's the process of recording information in a patient's health record? It doesn't really change whether it's electronic or paper. You want to record or document what is happening. So who shares the responsibility? It would be all members of the healthcare team. What are some of the types of documentation that typically fall into the realm? It would be patient contact, routine vital signs, any applicable patient education, communication and follow-up, prescription refills. And what problems can be the result of poorly maintained or inaccurate medical records, lawsuits, lack of adequate defense in a malpractice lawsuit, and reduced or denied claim payments. Over on page 39, what are the 4 primary objectives of HIPAA? We have to assure the health insurance portability by eliminating job lock due to pre-existing medical conditions, reduce healthcare fraud and abuse, enforce standards for health information, and guarantee security and privacy of health information. How does HIPAA affect claims submission and processing? Basically, the HIPAA standards mandate that a patient must sign a release of information prior to submitting claims, that most medical facilities submit claims electronically and in a specific format, and the use of transaction code sets, and then also new and improved security standards. What is incidental disclosure? Basically, there's visual and oral and verbal. The visual situations are where unauthorized individuals may see patient information, including your sign-in sheets, your patient boards, patient charts, patient room doors, or computer screens. Oral and verbal might be situations where unauthorized individuals might overhear patient information, such as leaving messages on answering machines, speaking on the telephone, calling patients in the waiting areas. These are all incidental. What is the best defense against committing violations against HIPAA? You want to set new safeguards for privacy. Oh no, sorry. How does HIPAA benefit patients? That was the next question. How does HIPAA benefit patients? Because it sets new safeguards for privacy. It allows patient access to their health records, permits faster turnaround time on claims due to electronic submission, portable group policies, limited pre-existing condition clauses on coverage, and it affords better protection from fraud. What is the best defense against committing violations against HIPAA? A written compliance plan. That's the best defense. Because if they walk in and you don't have one, there's a large penalty. What entity recommends that all medical facilities review standards and procedures to determine whether they are in compliance? That would be the OIG, which is the Office of Inspector General. Page 41, term for the foundation for trust in the patient-provider relationship. That would be confidentiality. How do we define confidentiality? It would be the protection of sensitive information from unauthorized disclosure. Whose responsibility is it to uphold this? It would be every member of the healthcare team. What are some of the exceptions? There are exceptions, believe it or not. Treatment of minors, HIV positive patients, and HIV positive healthcare workers, abuse of a child or adult, injuries inflicted by firearms or other weapons, and communicable diseases. Before divulging confidential patient information to any third party, what must health insurance professionals do? They must have a release of information signed by the patient or his or her guardian. On page 43, how does fraud differ from abuse? Fraud is the intentional deception or misrepresentation that the individual or entity makes, knowing that that representation could result in some unauthorized benefit to the individual or entity or another party. What is abuse? It is similar to fraud, but it is considered a bit less serious when it's applied to healthcare. Abuse can be defined as improper or harmful procedures or methods of doing business that are contradictory to accepted business practices. Who typically commits healthcare fraud? Just about anyone can commit health insurance fraud. Physicians, hospitals, medical suppliers, pharmacies, nursing homes, patients, insurance companies. What are several common ways that fraud is committed? Billing for services that are not provided to the patient, upcoding or unbundling or misrepresenting services. How can health insurance professionals prevent fraud and abuse? There's several ways, but just to name a few, create a file for every major third-party payer your office deals with. Keep current provider manuals, claims completion guidelines, publications up to date in order to aid you in your timely and accurate filing of claims. Develop a list of hot phone numbers to the carriers. Use the most current coding manuals and code to the greatest specificity. Take advantage of every opportunity to improve your coding skills. Discuss questions or potential problems, and notify your superior immediately when there's an issue that creeps up. Any questions on Chapter 3?
No.
Okay. All right, the types and sources of health insurance. On page 50, what are the 4 basic types of plans? We have, well, the basic types, 2 types. Indemnity, which is fee for service, and managed care plans. What's the difference between UCR and RVS? UCR is usual, customary, and reasonable. This is the part of the provider's charge that the insurance carrier allows as a covered expense. And this is the value of that provider's service that's based on historical data developed from the following. So these 4 things make up the UCR. How much the provider charges his or her patients for a same or similar service, the variance in the charges by most providers for the same service in the same geographic region, whether the procedure requires more time, skill, or experience than it usually requires, and the value of the procedure in comparison with that of other services. What you'll find in the RVS system are payments for services are determined by the resource costs needed to provide them. So the cost of providing each service is divided into 3 components: the physician work, the practice expense, and the professional liability insurance. Payments are then calculated by multiplying the combined costs of the service by a conversion factor, which is usually a monetary amount that is determined by CMS, and then payments are also adjusted for geographical differences in the resource costs. We mentioned earlier the name of the form that we use to submit claims is a CMS 1500 form. What effect does the Affordable Care Act have on pre-existing conditions? Basically, the ACA makes it illegal for health insurance companies to deny any applicant with a pre-existing condition. So that's a good thing. List 5 types of preventative services that qualify plans at no cost. blood pressure checks, many cancer screenings, counseling on topics such as smoking, weight loss, eating healthy, regular well baby and well child visits, routine vaccinations, counseling, screening, and vaccines, and flu and pneumonia shots. And how is managed care different from fee-for-service plans? Your managed care is the medical care that's provided by a corporation that makes medical decisions for the enrollees, and a healthcare provider tells the patient which physicians they can see and monitors the medication and treatments prescribed and ensures that all those things are followed up on. On page 52, what are the major differences between a group contract and an individual contract? A group contract is the contract of insurance made with a company, a corporation, or other group of common interest. And an individual health insurance is policy being tailored to the individual's preference, but your premiums are typically higher if that happens. True or false? There are no disadvantages to group health insurance. That would be false. Name at least 4 sources of health insurance. We have group contract, individual policy, Medicare, Medicaid, and so on. How does disability differ from workers' comp? Disability insurance is a form of insurance that pays the policyholder a specific sum of money in place of his or her loss of income if they cannot work because of illness, accident, or disability of some type. Workers' compensation pays workers who are injured or disabled on the job or has a job-related illness. All right, page 55. What are the 4 types of healthcare options? They are your health savings accounts, flexible spending accounts, health reimbursement arrangement, health insurance exchange, premium reimbursement arrangement, and accountable care organizations. The health insurance exchange offers a choice of plans with common rules governing how each plan is offered, its costs, and usually provides information to help the consumer better understand the choices that they have available to them. An HSA operates, an HSA will allow the individual to make a tax-deferred contribution to their personal retirement fund, and then they'll work in conjunction with the special low-cost, high-deductible health insurance policy to provide that comprehensive health care coverage at the lowest possible rate. What are the benefits of an FSA? That's a flexible spending account. And usually expenses for such items such as the health insurance premium and unreimbursed medical, vision, dental, child dependent care expenses paid before the deduction result in that immediate tax savings. What is the standard benefits and coverage rule? It requires that insurance work vendors provide consumers with a standard 4-page summary of benefits and coverage. And what type of health care typically falls in the category of long-term care? This is usually when an individual is stricken with a degenerative condition such as a stroke or Alzheimer's, performing activities of daily living. Over on the right of page 55 down below, to whom does COBRA law generally apply? Usually employees and their dependents who lose their jobs. What are the various events that qualify an employee for COBRA? Voluntary or involuntary termination, reduced hours of work, covered employees become entitled to Medicare, divorce or legal separation, death of a covered employee, and loss of a status of a dependent child. What medical benefits are included under COBRA? Pretty much the same thing: inpatient, outpatient hospital care, physician care, surgery, prescription drugs, that type of stuff. Over on page 56, what is the function of the Joint Commission? The Joint Commission evaluates and accredits nearly 20,000 healthcare organizations and programs, which includes almost 12,000 hospitals and home care organizations, and more than 7,000 other healthcare organizations. And it might be that they provide long-term care, behavioral health care, lab, ambulatory care services, those types of things. List the names of the organizations that function as healthy insurance watchdogs. That would be the Joint Commission, the National Committee for Quality Assurance, or NCQA, American Accreditation Healthcare Commission, Accreditation Association for Ambulatory Healthcare and Community Health Accreditation Program. Also, Consumer Coalition for Quality Healthcare. Page 57, bottom of the column. When a child is listed on both parents' health plan, which one pays first? It would be the parent whose birthday falls first in the calendar year. Doesn't necessarily mean who is older, just whose birthday falls first. What are some exceptions to the birthday rule? If the parents share the same birthday, if they're divorced or separated, active employees, different plan types. Some of the possible sources of overinsurance is where both the husband and wife are employed. And eligible for group health coverage, and each lists the other as a dependent. A person who is employed in 2 jobs, both of which group health insurance coverage. A salaried or professional person with group health insurance coverage with an employer who has an association group plan. And what are the 4 stipulations that determine medical necessity? The first one would be that they're proper and needed for diagnosis or treatment of a patient's medical condition, that they are provided for the diagnosis, direct care, and treatment of a medical condition, that they meet the standards of good medical practice in the local area, and that they are not mainly for the convenience of the patient or the healthcare provider. Any questions on Chapter 4?
I think I'm good.
Okay. So let's go on to Chapter 5. And if and when you want to take a break, let me know. We'll probably take one once we get through 5, if you want, just to get up, stretch, and use the facilities.
Okay.
I usually try to take one just around 7. All right, so Chapter 5 is all about claim submission methods. What is a claim submission or claim process? Basically what happens here is ends up being the interaction between the healthcare provider and the insurance company, which is considered to be the third-party payer. The cycle basically begins when the patient first steps through the door. They visit the healthcare provider and a chart is created or updated, whether it is a paper chart or an electronic chart. Then the health insurance professional, meaning us, would then transmit the information from the chart to the insurance company as a claim form. Then the insurance company evaluates the claim and processes it. So there are two basic methods over on page 64. Two basic methods of submission. We have paper and electronic. The paper form is that CMS 1500 form, and you want to make sure that you're always using the latest revisions. And with the new one, we have an addition of 8 diagnosis codes and the addition of the QR code at the top left-hand corner of the form. And then we have the electronic. With your electronic claim form in your practice management system, your practice management software makes it possible to manage the large numbers of insurance claims with the various payers more accurately and efficiently. With the computer technology that we have today, it basically has made claims submission faster and more accurate with cost savings. And what is HIPAA? HIPAA is the Health Insurance Portability and Accountability Act, and it's HIPAA, not HIPPA. And there are now only 2 ways to submit claims, as I just mentioned previously. It is electronic or paper. With HIPAA, we see Administrative Simplification Compliance Act. And what it revolves around is electronic transactions and code sets having standard requirements. Over on page 65, electronic transactions and code set requirements, privacy requirements, turn the page, security requirements, and national identifier requirements. So with the transactions and code sets, we have HIPAA version 5010 transactions and code sets. And it's gibberish to us in the billing and coding world because it really is all about computers. And what it comes up to is a HIPAA ASC times 12 version 5010. It's a new set of standards that regulates the electronic transmission of a specific healthcare transaction. Basically, all the data that we put into the software program spits out this foreign language on a claim form. Now, it doesn't look like anything when you see it in readable form. And I don't know if you can actually really read it. You understand that line by line by line means something. And so that when it gets received on the other end, it creates a form. And basically, it's in this HIPAA ASC time swell version 5010. It's an ANSI 5010 file, basically. And what it includes is the claims and patient visit information, the status inquiries, eligibility verifications, insurance payments and EOBs, patient insurance and plan enrollment and disenrollment, and referrals and prior authorizations. So what are some of the reasons for updating the standards? Well, on page 67, some of the reasons would be to implement some unforeseen issues and requirements that were discovered while they were usually using the version 4010, to accommodate the mandatory switchover from ICD-9 to ICD-10 code sets, to update the standards for electronic transactions to incorporate all the necessary changes that will occur when ICD-10 is implemented, and to reduce the transaction costs and minimize manual claim processing as much as possible and reduce the need for personnel. So what is the impact of version 5010 on claims on page 68? What is the impact? The impact would be that the provider's address can no longer be a post office box. The provider must be listed as the billing provider. Rules for reporting providers and MPI have changed. The subscribers, for the most part, are now the patients, regardless of who purchases the policy. This is very important. Subscribers, for the most part, are now the patient, regardless of who purchases the policy. The only exception here is if there is a suffix in the last name. Medicare's claim submission on page 70. Medicare's claim submission requirement. The ASCA requires all claims to be submitted to Medicare to be electronic with limited exceptions. Because they are electronic, they must be HIPAA compliant. The electronic insurance claims process. The essential information that they're looking for is to get the patient demographic information, record current insurance information, keep the patient's health records up to date, and give provider authorization to release medical information and accept assignment. What is accept assignment? It is that you, the payer, will get paid, not the patient. So new patient information on the bottom of the page, bottom right-hand column of page 70, new patient information. Now you see the new patient information form on page 71. Well, if you turn the page to 72, you'll see what a standard EMR looks like. This is practice management software, and actually this looks pretty much like a program called Metasoft that I'm very familiar with. And you'll see that you get the general demographic information, and we also want to know the financial status, and if it's a self-pay account. We also want to obtain any treatment consents, release of information, and social security number. Then with the insurance section, you want to have the patient fill out their section, also make a copy of their driver's license and their insurance card. And some of your patients may be covered under more than one policy, so make sure you confirm whether or not they have additional insurance. And you'll see on the page, bottom page 73, that sample of a card. And you want to get the front and the back, because on the back of that insurance card, believe it or not, is where they tell you to send the claims. Or if providers have a question, this is where you call. The patient health record over on page 74, the complete record should outline the reason for the patient's visit. And you'll see an example of a clinical note down below, documenting the healthcare findings, including detailed discussion of recommended treatment, providing information to referring physician or other healthcare provider, serves as a teaching and/or research tool, and it provides a means for assessing the quality of care. You'll notice on page 75 they have a paper encounter form. That encounter form, basically, some places are still using one, and it tells the front desk what the patient had done. And you see examples there of the different types, and it tells you what was done plus the code and then how much it costs. The patient ledger card. The patient ledger card will account the professional service fees, the charges, the payments, the adjustments, and the current balance. And you'll see an example of an encounter form on page 77 and what the sample statement printout looks like. When you're verifying insurance with technology, over on page 79, you can use the IVR system, which is an interactive voice response. You also have swipe terminals and internet-based eligibility check systems. Be very careful using the internet-based eligibility check systems because they might not be specific to specialties. Let's talk about the electronic billing process and how it evolved, or how the evolution of the CMS 1500 form came into place. So what are the advantages of electronic claims? Over on the right of page 79. A lot of experts will tell practitioners that processing insurance claims electronically will improve the cash flow, reduce the expense of claim processing, and streamline internal processes. Well, believe it or not, that's the truth. Because Anthem happens to be the biggest payer here in the state of Maine. And I can tell you right now, when I'm submitting claims electronically, I get a check turned around within 8 to 14 business days. So I know if I get it out by Friday, they process their claims by Tuesday or Wednesday of the following week, and a week later I have a check. And it's either EFT or paper check, but they're the fastest payer. So definitely electronic claims does improve cash flow. There are two ways to submit those claims. It is either through a clearinghouse or directly to the insurance carrier. Your clearinghouses usually have a fee attached to them, depending on how many claims you send out. Your payers usually are free, but it means that you have to have separate logins for all the different sites that you utilize. With the claims clearinghouses, HIPAA defines this as a public or private entity that processes or facilitates the processing of non-standard data elements of health insurance information into standard data elements. What do the clearinghouses actually do? They act as a point of entry. They check for the validity and accuracy. You route the claims on the proper carrier, and you return the claims with errors and or omissions to the provider. And usually you can get those worked and right back out the door within 24 hours. Direct claims, bottom of page 80. These are more complicated because then you have to enroll with the carrier. Often you will have additional software to be compatible with the carriers, and most common method is sending a print image file of a claim. Your clearinghouses versus direct. This means that the carrier direct is usually less expensive if the medical practice submits most claims to just one carrier. When you have multiple carriers being used, a clearinghouse is usually less expensive. As I mentioned, depending on the type of payers that you participate with, you might want to use a clearinghouse so you're logging in once and one time only, and you have access to all the payers' information that you need. The Universal Claim Form, the CMS 1500 form, again, version 212 is the most current version being used, and your NUCC provides current, detailed step-by-step claim completion instructions. So make sure you reference that if you need it. The OCR is the optical character recognition. You want to use this for formatting guidelines when completing the CMS 1500 form. It is printed in red ink to optimize the OCR, and when it is scanned, the red drops out, and the computer reads only information printed within, and I mean within, the blocks. Because if it is a smidge outside the box, they will deny that whole claim for being a little smidge outside the box. I'm not kidding. The formatting of the OCR, you'll see on page 82 exactly what I'm talking about. You have to have everything exactly in line in the box. The format of the form is an 8.5 by 11 inch. It is two-sided document. The front is printed in OCR scannable red. The back of the form contains instructions for various government and private health programs. And there's two sections, the top portion and the bottom portion. The top portion is the patient and the insured information. The bottom portion is for the physician and supplier information. Who uses the paper form? Providers who are not computerized and who do not have the capability of submitting claims electronically. Small providers who fit the previous description. And other special situations are listed in box 5-1 of the textbook on page 67. Proofreading. Proofreading your claims, if you send them on paper, is very, very important because a clean claim means quick payment with no rejections. Make sure it's signed by the physician, that there are no errors or omissions, and that if you have attachments, that they are attached. Some common attachments for claims on page 83 would be certificates of medical necessity, or CMN, discharge summaries, and operative reports. If you're doing a surgery, you always will have reports. To track your claims, turn the page on 84. Tracking your claims, on the bottom of page 84, figure 5-15, you'll see that there is a claim tracking function within your practice management software, so you can see when you sent them, when you created them. And over on page 85, you can see a sample insurance claim tracking form if you really wanted to set something up for yourself. And you also can run a primary aging report so that you can see on any given time when you last submitted claims and how long have they been sitting out there and who do you need to call, the patient information that's there and such. And that can be very helpful. Any questions on Chapter 5?
I don't really have any questions. No.
Okay. Why don't we take a quick 5 minutes and we'll come back and cover as much as we can until the end of class.
Okay.
Okay? All right, Chapter 6. Page 88. Traditional fee-for-service and private plans. With the traditional fee-for-services or the indemnities, the patients can actually choose any doctor, and they can change doctors anytime. They do have coverage at any hospital. So let's just review for a moment. Third-party payers. Your third-party payers, they cover the major portion of the insured's medical expense. I'm on page 89. Your group insurance. Your group insurance is the contract between the insurance company and the employer that will then cover the eligible employees or their members. Then you have the managed care, which is a group of providers who share that financial risk of the plan, and they have an incentive to deliver a cost-effective but quality service. We have 4 basic types of plans over on page 90. 4 basic types of plans. Your traditional FFS, which is fee for service, and your indemnity plans, your preferred provider organization, your point of service, and your HMO. So FFS, PPOs, POS, and HMOs. Which one is the best? Well, there is no one type of healthcare plan that is universally better than the other. It just depends on the group or individual's needs and preferences. That's what it comes down to. What are some of the standard costs for your FFS? Well, a monthly or a quarterly fee called a health insurance policy premium. This is usually a yearly deductible that comes out of pocket before the health insurance carrier will begin to contribute. And a per visit coinsurance or percentage of the health care expenses. How does the FFS plan work? We're on page 90 on the right-hand column. Actually 91, left-hand column. How does the FFS plan work? The healthcare policy is purchased. That's the first step. Then we have periodic payments or periodic premiums that will be paid. And then the patient will pay their specific amount, which is a deductible annually, before the FFS plan will begin to pay. Now, some of your FFS plans have an insurance cap, and this is called a stop loss. What this does is it limits the amount of money the policyholder has to pay out of pocket for any one incident or in any one year. Then we have a lifetime maximum cap. This is an amount after which the insurance company will not pay any more of the charges that are incurred. Then we have reasonable and customary, This refers to the fees that are commonly charged for professional health services within the specific geographic area. A PAR, or a participating provider, agrees to accept the third-party carrier's reasonable and customary fee as payment in full. Over on the right of page 91, we're going to talk about resource-based relative value scale, or the RBRVS. This is a system of payments established by the Centers of Medicare and Medicaid. They, in turn, help to reimburse the healthcare providers for treating Medicare patients. This takes into account the work done by the physician, the cost of the malpractice insurance, and the practice expenses. That includes your staff salaries, your overhead, and your supplies. Over on page 92, let's talk about healthcare reform and pre-existing conditions. We talked about pre-existing conditions earlier in Chapter 4. Before the Affordable Care Act, your pre-existing conditions were excluded from the coverage under some of the policies, or there was a specified length of time that had to elapse before the condition was covered. With the Patient Protection and Affordable Care Act, it changed the pre-existing condition requirements. So HIPAA also affords some protection, which is considered credible coverage, over on the right-hand column of the page underneath HIPAA and healthcare reform. With your commercial and private health insurances, over on page 93, any kind of health insurance coverage that's available from your private and or commercial entities other than the government would be commercial health insurance. If it's paid for by the employer, the union, the employee, and the employer or individual, there's also a high risk pool, and the coverage was mandated in 2014. And also was also part of the health insurance exchange. What is self-insurance? Self-insurance, over on page 94. Self-insurance, we hear commonly referred to a system in which the employer assumes all or part of the responsibility for paying the health insurance claims of their employees. That firms that self-insure for health claims are exempt from state insurance laws mandating the illnesses that group health insurers must cover. So if we have a company that self-insures the health claims that are exempt from the state insurance laws, that would be self-insurance. Your Employee Retirement Income Security Act of 1974. This is called ERISA. ERISA establishes guidelines for private pension and employee benefit plans. There are guidelines that affect how the self-insured employers fund their programs. Your third-party administrators and administrative services organizations, your TPAs. These are the business entities that actually process the claims, and they might also perform other contractual administrative services for those self-funded plans. It's just a matter of knowing what they do. They are neither the healthcare plan nor an insurer. but they get money for helping or providing these services. Your single or specialty service plans. These are health plans that provide services only in certain specialties, something like your mental health, your vision, or your dental plans. It would eliminate a certain specialty of health services from policy coverage. So just know what is covered under those plans. If they do eliminate a certain specialty of health service from a policy coverage, that is considered or referred to as a carve out. Your Blue Cross and Blue Shield. This is the best known commercial insurance company in the country. It's also one of the largest ones here in Maine. It is a national organization that is made up of 39 independent regional companies that provides healthcare coverage to more than 98 million Americans. We have the Blue Card program. It links independent blue plans that allows members to obtain the same healthcare benefits while traveling or working anywhere in the United States. It also, to identify the members who participate in the Blue Card program, you would look for the suitcase logo on the ID card. If the member belongs to the Blue Card PPO, the initials PPO will appear inside the suitcase logo on the card. And Blue Card Worldwide, they also provide a blue plan members with the inpatient and outpatient coverage at no additional cost in more than 200 foreign companies. Your FEHB or FEB or FEP is called your Federal Employees Health Benefits Program over on page 98. It is the largest employer-sponsored group health insurance program in the world. And it covers over 9 million federal civilian employees, which includes former employees, family members, and former spouses. The Federal Employee Program, FEP, also provides health benefits coverage for its federal employees. It has covered federal workers and their families since 1960 when the act was adopted. And your Blue Cross Blue Shield FEP covers nearly half of all people eligible for the FEHB program benefits. Your Blue Cross Blue Shield and Medicare partnership began in 1966. It is one of the largest single processors of Medicare claims. Your healthcare service plans, again, are your FFS, HMOs, PPOs, POS, and CDHPs. Your indemnities are the FFS. Your HMOs, PPOs are your managed care. Your POS is your point of service plans. And your consumer-directed health plans are your CDHPs. Your Medicare supplement plans are the MSPs over on page 99. These are also, your Blue Cross Blue Shield also offers Medicare supplement plans, which are your MSPs. and these are also called Medigap plans. Your participating versus non-participating providers. A PAR is a participating provider. They agree to file their claims within contracted time frame, accept the Blue Cross Blue Shield allowed fee as a payment in full and write off any differences. Blue Cross Blue Shield agrees to send payments electronically or send payments directly to the provider, host periodic staff training, offer guides and newsletters, provide assistance with claim problems, published with the practice's information in the Blue Cross Blue Shield PAR directory. Your non-PARs, these are providers who are not part of the previously described contractual agreement. They are referred to as non-participating providers or non-PARs. They do not have to file patient claims. They can balance bill the difference between their charges and Blue Cross Blue Shield allowed charges. Submitting your Blue Cross and Blue Shield commercial claims, the Blue Cross Blue Shield member office. The Blue Cross Blue Shield office publishes the specialty and specific billing guides. These guides can actually be viewed online under the provider guides on most of your member websites. Paper copies are also available upon request. You would just have to call the payer and find out. Timely filing, over on page 100. Blue Cross Blue Shield PARs must file claims within 365 days following the last date of service provided to the patient. Filing electronic claims, you must adhere to HIPAA guidelines. You, as the health insurance professional, should review the electronic claims receipt. Any claims with errors must first be corrected and then resubmitted electronically. Your commercial claims involving secondary coverage, you want to find out which policy is primary and submit the claim to the carrier first. The EOB is then sent from the primary carrier to the secondary carrier. And your ERAs, or your electronic remittance advices, which is where they tell you what they paid. This is also part of that ANSI 5010 code set and transactions. The ERAs are over on page 103 in your textbook. Any questions on this chapter?
No.
Okay. Then let's move on to Chapter 7, the mysteries of managed care. On page 106. So what is managed care? Kelsey, what do you think? What is managed care?
I'm guessing it's these bullet points here. The economic
Yep.
incentive for physicians and patients to select less costly forms of care.
Yep, pretty simple and straightforward. Basically, it's a huge network where all of your physicians, your hospitals, and other healthcare physicians, they organize this system and they communicate with one another to work in referring patients back and forth. That's pretty much what managed care is. And there's three main functions. first thing they do is they set up the contracts and the organizations of the healthcare providers who are going to furnish all this medical care to the enrollees. Then they establish the list of covered benefits that are going to be tied to these managed care rules. So I'm on the bottom of 106 and the top of 107. Then what they do is they oversee the health care provided by the MCO. So then we have common types of managed care. And there's two main types over on the right-hand column of 107. We have the PPOs, which we've heard many times already in the last few chapters, and then the HMOs, the Health Maintenance Organizations. So over on page 108, the PPOs, the Preferred Provider Organization. This is pretty popular throughout the U.S. It is a network of our healthcare providers that have agreed to provide medical services to our health plan members at discounted costs. The members will make their own decisions about their health care rather than going through the primary care physician, like the HMO members. And the cost to use the physicians within the PPO network is less than using a non-network provider. So why are they popular? Because they don't need a PCP to oversee their total care. They don't need special authorization to visit specialists or other healthcare providers as long as they are in that PPO network. And then they're not as tightly controlled by the laws and regulations as the HMOs. So what are some of the disadvantages? Well, they are loosely controlled. So they're not much better at controlling cost than the traditional fee-for-service health insurance, which results in higher premiums over time. So a more tightly controlled PPO can actually reduce patient choice. Our HMOs on page 109 is the plan that provides the healthcare to the enrollees from specific doctors and to the hospitalists or hospitals that contract with the plan. So there's usually not a deductible to be met, there's no claim forms to be completed, and it operates usually in a geographically restricted service area. With the HMOs though, your enrollees have to choose a PCP, and that means that they have small or no co-payments at each visit. So what are some of the types? We have a staff model and a group model. Our staff model is our multi-specialty group practices, where usually all the services are provided within the same building. Our group model is one or more physician group practices, not usually owned by the HMO, but they operate as independent partnerships or professional corporations. Over on page 110, we have the network model. This allows the multiple provider arrangements. It includes the staff, the group, and the IPA structures. Your mixed model, this describes certain HMO plans in which your provider network is usually a combination of delivery systems. Then we have the direct contract model, which is similar to your IPAs, except your HMO contracts are directly with the individual physician. And then we have the Independent Practice Association, the IPAs, which contracts with the HMOs on behalf of the groups of the independent physicians who work in their own offices. There are other types of managed care organizations, your points of service, your provider-sponsored organizations. The POS model is the hybrid of the managed care and the traditional indemnity, under which the insured can choose whether to use a network or non-network provider. The provider-sponsored organization, the PSOs, these are referred to as your Medicare Advantage plans, and they provide Medicare beneficiaries with alternatives to the original Medicare. Some of the advantages of your managed care. Preventative health care is encouraged. They have lower premiums. We see lower co-payments for prescriptions. We see fewer unnecessary procedures and tests and limited paperwork. What are some of the disadvantages over on page 111? Well, we have a limited provider pool. We have restricted coverage. Usually you have prior approval needed, and there's possibility of undertreatment and compromised privacy. With your managed care and the Affordable Care Act, the major goal of the Affordable Care Act is to provide the quality and affordable care for all Americans. So your experts believe that healthcare reform will ultimately lead to some form of a managed care model with limits on spending, such as access, cost, and quality. The managed care accreditation and regulation, you're going to see here that most are regulated in three areas, the states, the federal government, and voluntary accreditation. The voluntary accreditation is your National Committee on Quality Assurance, the Joint Commission, and your URAC. On page 112, the NCQA is an independent, not-for-profit organization that measures, assesses, and reports on the quality of care and service of your HMOs. NCQA standards are particularly going to be useful for focusing on those MCOs' quality programs and helping to prioritize the important initiatives. NCQA and HIPAA you'll see that NCQA's privacy and confidentiality requirements also reflect key HIPAA elements. The Joint Commission, on page 112, the Joint Commission, this is an independent nonprofit organization. It evaluates and accredits healthcare organization. There are standards that are outlining that outline performance expectations for the activities that affect the safety and quality of our patient care. The mission here is to continuously improve healthcare for the public in collaboration with the other stakeholders. They usually evaluate healthcare organizations and try to inspire them to excel in providing safe and effective care for the highest quality and value. The URAC, formerly known as the Utilization Review Accreditation Commission, this is a nonprofit organization that promotes healthcare quality by accrediting many types of healthcare organizations. They depend on the functions that they carry out. A utilization review is a system that is designed to determine the medical necessity and appropriateness of a requested medical service, procedure, or hospital admission prior to, during, or after the event. This, you will see, is used in many managed care plans to reduce that unnecessary medical inpatient or outpatient service. Complaint management. Medical services and procedures determined not to be medically necessary will not be paid by the insurer. If the patient disagrees, a grievance or a written complaint may be filed to protest that decision. Situations prompting grievances. An insurer's decisions, policies, or actions are related to availability, delivery, or quality of healthcare services. Other things might be claims management, a contractual relationship between a covered person and an insurer, or the outcome of an appeal. What is pre-authorization and pre-certification on page 113? You're going to find that both of these terms refer to the method by which a patient is pre-approved for the coverage of a specific medical service, procedure, or prescription drug. A pre-certification may also be used during the process by which a hospital notifies a health insurance company of an inpatient admission, which is a pre-admission authorization. The predetermination of benefits. This will allow the medical provider at the patient's request to send an insurance company a statement explaining a proposed treatment or test or the planned purchase of medical equipment. The patient might even be able to review the costs and possible reimbursement to allow him or her to make a decision before that test or procedure is performed. A referral over on page 116. A referral is a request by a healthcare provider, typically the PCP, for a patient under his or her care to be evaluated and or treated by another provider, usually a specialist. The purpose for this is to inform a specialist that the patient needs to be seen for a second opinion, or to inform the insurance company that the PCP has approved the visit to a specialist. Referrals versus consultations. A consultation is something that occurs when the PCP sends a patient to another provider, usually a specialist, for the purpose of gaining an expert opinion regarding the patient's condition. Usually for that purpose, as an expert opinion. So imagine this. Daniel Bowers visited Dr. Adler, his PCP, with complaints of back pain and numbness in his left leg radiating down to his left foot. Dr. Adler x-rayed Daniel's spinal column and discovered a degenerative disc condition and subsequently referred him to Dr. Langford, who specialized in degenerative disc disease. Susan Lane, another patient of Dr. Bowers, complained of heart palpitations during an office visit for treatment of a severe case of poison ivy. After performing an electrocardiogram, Dr. Bowers informed Susan he was sending her to Dr. Woodley for a stress electrocardiogram and an echocardiogram to determine whether her palpitations represented a serious cardiac problem. While in the hospital for a hip replacement, Evelyn Connor was diagnosed with diabetes. Dr. Blake, her surgeon, asked Dr. Martin, a specialist in endocrinology, to manage Mrs. Connor's diabetic condition. All of these events, each of these cases, warrant a consultation, an expert opinion on what else might be going on with that patient. They get a referral. So Daniel Bowers is going to be a referral and a consultation. Same with Susan Lane. Same with Evelyn Connor. HIPAA and managed care on page 118. Your HIPAA regulations affect the following 4 areas of healthcare. They're listed on page 118 there in your book. First one is to maintain patient confidentiality, implement standards for electronic transmission of transactions and code sets, establish national provider and employer identifiers, and resolve security and privacy issues arising from the storage and transmission of healthcare data. What is the impact of managed care? It simply is a shift from traditional systems to managed care networks in the response to market forces for cost control, regulatory initiatives on cost and quality, and consumer demands for quality care and greater flexibility in provider choice. So what is the impact of managed care on the physician-patient relationship? It might actually change the way in which those begin and end because of restricted access and termination of relationship without patients choosing. Remember, your PCPs function as the gatekeepers. So what we're going to see is a shift toward managed care requiring providers to do one of the following things. And you'll see on page 119 that they would have to become participants in a larger provider practice structure, become participants in integrated delivery systems, and or become employees and service providers for large insurance organizations, HMOs, or both. So what would we consider to be positive impacts over on the right-hand column?
The HMO physicians spent more time with their patients than fee-for-service physicians.
Yep.
And then those following bullet.
Yep, absolutely. So there are positives and there are negatives. We just have to look at both of them. Over on 120, the future of managed care. Some of the predictions that are out there are that the MCOs will begin competing among themselves and with new types of plans, and that the cost and efficiency may no longer be the main selling points because they're being replaced by quality of services. So even though we've come a long way, you're going to see that, you see it already. More and more plans have higher and higher deductibles, and patients are not, able to afford the care because of the higher deductibles. And if they have flex spending accounts, they're waiting to use them until they absolutely have to, because they don't have that extra money sitting in an account somewhere. All right. Let me just take a look here. All right. Any questions on Chapter 7, Kelsey?
No. Not right now, anyway.
Is the pace okay for you?
Yeah, sometimes it's like I know you're going in order, but sometimes it's hard to kind of figure out where in the paragraph you are. But I'm doing okay.
Just stop me, okay?
Okay.
Because,
Yep.
because it's a little harder when there isn't a lot of students to interact with. So
Yeah.
I try to do a kind of slow rhythm and try to keep on track and let you all know where I'm at. But I definitely need the feedback. So if I am going a little too fast, you have to let me know, okay?
Okay.
What I do hear from students who do it online is that what they like is that they can start and stop me.
Yeah.
So, Chapter 8, Understanding Medicaid. Medicaid on page 125 is a combination of your federal and state assistance programs that provides medical care for those qualifying low-income individuals. And that would be people, children, pregnant women, elderly persons, disabled persons, parents with dependent children who have no other way to pay for health care. And that should all be in that first paragraph. Some Medicaid facts. There are 56 different Medicaid programs. Basically, one for each state and territory and the District of Columbia. So middle of the paragraph.
Yep, I see it there.
There we go. Benefits are federally mandated, and additional benefits are going to vary state to state. Underneath Medicaid and healthcare reform, the Affordable Care Act made up the Patient Protection and Affordable Care Act and the Healthcare and Education Reconciliation Act of 2010. So it's the first sentence in the paragraph underneath the bullet points. And what this did was it expanded Medicaid coverage to millions of low-income Americans, and it introduced improvements to both Medicaid and CHIP. With the development and structure of Medicaid, it was originally created to give groups of low-income Americans access to health care. So today it is a major social welfare program that is administered by CMS, which was formerly called the Healthcare Financing Administration. Eligibility is based on need, which is determined by whether the patient meets certain income and resource limits. The federal government's rule is to determine whether a state is in compliance with Medicaid benefit and eligibility standards. So each state is to establish their own standards within the federal guidelines. Under the Affordable Care Act, most states will receive an increased federal matching rate. Title 19 of your Social Security Act, over on the next page, mandated services, requires to provide mandated services to the needy population to receive those matching federal funds. Temporary assistance for needy families, over on page 127. Your federal state cash assistance program for poor families, typically headed by a single parent. That's one part of it. Each state sets its own income eligibility for the TANF guidelines, which is TANF, and individuals who are eligible for TANF automatically qualify for Medicaid. The Children's Insurance Program provides federal matching funds for states to implement health insurance programs for children and families that earn too much to qualify for Medicaid, but too little to reasonably afford private health coverage. There are actually two options for states over on the right-hand column. Creation of a separate children's health program and expansion of eligibility for benefits under the state's Medicaid plan under that Title 19 Act. SSI, or Supplemental Security Income, this provides federally funded cash assistance to the elderly and the disabled poor. It's also a cash benefit program controlled by the Social Security Administration, but it is not related to the Social Security program. Your SSI income eligibility. You must be at least 65 years or old or blind or disabled or have limited assets, meaning financial resources. Your income limits are determined by the Federal Poverty Guidelines, or FPL. Your Medicaid eligibility over on page 129 is based on income and other specific circumstances. The children and families with incomes up to a certain percentage of the FPL, parents whose income limits vary by state, and persons with disabilities. These are what is considered Medicaid eligibility. The Medicaid expansion under the Affordable Care Act on page 129. More people can qualify for Medicaid under the expanded eligibility rules. Basically, your states that expanded Medicaid increased eligibility levels to 138% of the federal poverty level. All states that expanded Medicaid have a uniform eligibility requirement. Expansion almost exclusively covers the working poor and their families, and it helps cover gaps between current Medicaid eligibility and families being able to afford private health insurance using marketplace subsidies. Over on page 131, miscellaneous Medicaid programs. We have Community First Choice option. This is a relatively new state option. It gives individuals with disabilities who are eligible for nursing homes and other institutional settings options to receive community-based services. There is the maternal and child health services, the early and periodic screening, diagnosis and treatment program, the program for all-inclusive care for the elderly, and Medicaid home and community-based services waivers. Your Medicaid contractors, page 132. Medicaid does not process claims. The states contract with an organization specializing in administering healthcare programs. Your contractors actually bid for the job. Cost sharing, Medicaid programs and cost sharing. Your Medicaid beneficiaries pay a portion of their health costs. It might be deductibles, coinsurance, or co-payment amounts. The groups are exempt from paying premiums, and cost sharing include but are not limited to those groups: children, pregnant women, and people receiving hospice care. Services that are excluded from the cost sharing charges include but are not limited to emergency, family planning, and qualifying preventative services. The prescription drug copayments on the right-hand column of 133. The states may establish different copayment schedules for the generic versus brand name drugs or for drugs included on the preferred drug list to encourage the use of the lower cost drugs. The Emergency Medical Treatment and Labor Act. This is Medicare participating hospitals that offer emergency services. They must provide a medical screening exam and or treatment for an emergency medical condition that includes active labor regardless of the individual's ability to pay. Non-emergency use of emergency departments may incur a cost-sharing fee. You'll see that the care and services may be withheld if the individuals do not meet their cost-sharing obligations. The maximum nominal out-of-pocket costs. This is where the maximum copayment that Medicaid can charge is based on what the state pays for that service. Turn to page 134. The amount that a state may charge for premiums and or cost sharing is based on the individual's family income. Your payment for Medicaid services. Medicaid payments are made directly to the healthcare provider. Your PARs must accept Medicaid reimbursement as payment in full. Each state will determine how reimbursements are calculated and the resulting rates for services with 3 exceptions. The first being medically necessary. No, sorry. The 3 exceptions are for institutional services, for disproportionate share hospitals, and hospice care. Those are underneath the payment for Medicaid services. Medically necessary. What do I mean by medically necessary? Medically necessary is when Medicaid considers a service to be medically necessary. It typically must be consistent with the diagnosis, in accordance with standards of good medical practice, performed at the appropriate level, and provided in the most appropriate setting. Dual eligibles. All states have chosen the option of providing prescription drug coverage for their categorically needy populations. Most of this covers some or all. Dual eligibles will no longer receive prescription drug coverage through their state Medicaid programs. It will be through Part D. When you are accepting Medicaid patients, physicians actually choose patients with Medicaid only or patients with any combination of Medicaid and other health insurance. The number of patients can be limited within certain limitations. Your participating providers can elect to accept or refuse Medicaid patients. Those who elect to treat one Medicaid patient must treat them all. A provider cannot single out which one of these patients to treat. When you are verifying Medicaid eligibility, you use the patient's Medicaid ID, you use the AVR, you can also use electronic data interchange, use a point of sale device, and use a computer software program. Any one of those to verify their benefits. The ID card, when you are using the ID card, verify their name and other identifying demographics. On page 136, you'll see an example of a card there. Check the eligibility period from and through. Look for their insurance information. Ask them if they have any other insurance coverage. Photocopy the ID card and enter any new information into the patient record. I'm not going to go over the other types of verification systems. You see them listed on page 137, the AVR, the EDI, the point of sale, and the computer software program. Just review those.
Okay.
Your Medicare and Medicaid relationship. This is a dual coverage or dual eligibility. You'll see this listed sometimes as Medi-Medi. That means they have Medicare and Medicaid. Your very poor elderly or disabled individuals will have this coverage, and they may receive care and services from both programs. Page 138, special Medicare and Medicaid programs. We have the Qualified Disabled and Working Individuals, which is QDWI. They can purchase Medicare hospital insurance or supplemental medical insurance coverage. You also have people who might have qualified Medicare beneficiaries, QIMBYs, and then specified low-income Medicare beneficiaries. What is the difference between Medicare and Medicaid? It's listed on page 139. You can just review that back and forth, see what the difference is. Your Medicaid managed care over on the right-hand column, 138. Your MCOs are the most common method of delivering health care in the Medicaid program. You will see that there are a variety of health plans that serve your Medicaid MCOs. It also, your healthy children and families will make up the majority of the Medicaid managed care enrollees. Medicaid claims on 139. You also will use a CMS 1500 form. There is a time limit for filing. It does vary from state to state. Medicaid is usually a secondary claim, and there is resubmission of Medicaid claims. Just like anything else, if it's denied, you can resubmit it as long as you correct it. Medicaid and third-party liability on page 140. Some examples of third-party liability which typically pay for services would be your group health plans, your self-insured plans, the employee-related health insurance, court-ordered health insurance, workers' comp, long-term care, other state and federal programs. Your healthcare providers are obligated to inform Medicaid of any known third parties who may have liability. So if you know that the patient has another insurance and Medicaid, you need to let Medicaid know, because that means that other insurance is first. Some common Medicaid billing errors on page 141. You want to create and submit clean claims. That's the topmost primary goal. And then avoid making common billing errors. And they do list some of them in the book there for you. The Medicaid remittance advice. This is a document you'll see an example of on page 143. It explains how a claim is determined. It's formally referred to as an explanation of benefits, or COB. It can be paper or electronic, and it contains remarks and reason codes on how things were processed. For special billing notes, right-hand column of page 142. The time limit for filing claims, 2 months to 1 year. It does vary by state. The co-payments that you collect, check the ID cards. When you are accepting assignment, balance billing is not allowed. What does accept assignment? It means that you will get paid. The provider gets paid when you accept assignment. There are certain services that do require prior approval. It does not necessarily guarantee payment. Pre-authorization is required for all inpatient hospitalization unless it's an emergency. To retain records on when you're retaining records, you want to maintain records for 6 to 7 or even 10 years. Storage, you must locate the records quickly and easily, or be able to. And to dispose of them, you want to perform that according to state statute. So whether it's shred, erase, or delete. We spoke about fraud and abuse earlier. Fraud and abuse on page 145. Fraud is the intentional misrepresentation or deception, usually in the form of false statements resulting in unauthorized benefits. Abuse, payment for services resulting from poor and inefficient claim submission practices. Usually there's no intent involved. Medicaid quality practices, right-hand column of 145, the right care for every person, every time. The CMS key strategies are evidence-based care and quality measurement, payment aligned with the quality, health information technology, and information dissemination and technical assistance. The Medicare or Medicaid Integrity Program, or MIP. This is a comprehensive federal policy that is established to prevent and reduce provider fraud, waste, and abuse in the Medicaid program. They list 2 bullet points there. What is our role in health insurance? It is to learn the specific guidelines for Medicaid programs that's offered in our state. Contact the Medicaid contractor in your state to obtain a guide that lists what programs are available. One thing I will point out in these chapters is if you get through the chapter, read the summary checkpoints, because those pull out the important parts of the chapter for you. I will let you know that this book is not on the national exam, so I don't want you to be concerned about memorizing anything in this book. It's not something you're going to memorize. We did not get through all of the work that I wanted to for tonight. So for next week, what I will cover is 9 and 10. And then it looks like 11 through 16. So we did 5, 6, 7, 8 tonight. It looks like we're probably going to cover 4 chapters in a session. So for next week, let's do 9, 10, 11. I'm not going to do, let's see, 12. Diagnostic coding. Let's do 9, 10, 11, and 12 for next week. So you probably got half of it already done. And what I would suggest is that the questions throughout the chapter, what did you learn? They're usually more than 1 or 2 questions. Only do the even one. So let's say in chapter 5, we have page 64. There's 1, 2, 3, 4. Do 2 and 4. On page 66, do 2, 4, and 6. All right, so from here on out, we'll do the even numbered questions throughout the chapters in the what did you learn boxes. Okay?
Okay.
So for next week, 9, 10, 11, 12. Even numbered questions and what did you learn? And any last minute questions?
No, I don't think so.
Okay, so what is your takeaway from tonight, Kelsey?
I definitely feel like I have to go back and read through what we did cover. It seemed like more to take in than last week's.
Okay, start out with the summary checkpoints just to see if maybe that helps first.
Yeah,
That would be at
well,
the end of every chapter.
yeah.
Okay, so this will be available Friday if you want to request the link.
Okay.
Just sometimes people have it playing in the background while they're trying to do some work. But thank you for joining me tonight. And again,
Thank you.
if you're not able to make class, just let Gardner and myself know.
Okay. I will.
Okay?
Yep.
All right. Thank you.
Thank
Have
you.
a great night.
Yeah.